Good morning and welcome to the Harvard Anesthesia Update 2022. My name is Eswar Sundar. I am anesthesiologist at Beth Israel Deaconess Medical Center, and I am one of the directors for one of the campuses. So today I am going to be talking to you about evidence-based management of obstructive sleep apnea. And we will go through a bunch of objectives and discuss some of the latest developments in this field. I have no disclosures. So the objectives of this lecture include discussing the impact of obstructive sleep apnea on healthcare, the importance of screening and limitations of the tools we currently have for screening, what possible interventions that can be applied to patients who are at high risk. We're going to discuss a little bit about the BIDMC OSA management pathway and look at guidelines put out by societies for the perioperative management of patients with OSA or suspected OSA. So let's roll the clock back. It is 2005, 17 years ago, and life is generally good. And at that time at our hospital, this happened. We had a very obese male who, with sleep apnea, was not CPAP compliant, had an uneventful anterior cervical fusion discectomy, was administered morphine for pain relief, delayed extubation of the PAPQ, more narcotics, more sedated, finally went into apnea desaturation. We were called emergency anesthesia stat. We were unable to re-intubate, and the patient passed. A few months later, we had a more normal-sized female, also with OSA, CPAP non-compliant, had a hemiarthroplasty, had a very difficult intubation, needing a Bullard laryngoscope, which is an old-fashioned video laryngoscope, actually. After an uneventful surgery, again, I went to the floor or ward and had morphine for pain relief. But on post-op day one, had a code blue, and they were unable to rescue or re-intubate the patient, and the patient subsequently passed. So what does the legal literature tell us about OSA? So this is a review which appeared in 2016 in Anesthesia and Analgesia, which looked at close claims for cases related to sleep apnea. So the findings of this close claim project involved 24 cases, and most were male and were on the younger side. The average age was about 41. But 21% of the complications happened intraoperatively, about 33 in the recovery room, and about 46% on the surgical floor. So it looks like the most common complication site was either in the recovery room or thereafter on the wards. And the most common complication was a difficulty in rescuing the airway. Immediate death happened in about 45%. A similar number had anoxic brain injury, and a good percentage had airway trauma in the attempt to intubate. Close to 3/4 of these patients subsequently died after these events. And what were the court's verdicts on these cases? They favored the plaintiffs in about 58% of the cases and favored the defendants in 42% of the cases. Now, this is completely inverted in what would normally happen in a medical legal case, because defendants, usually are able to win cases, and plaintiffs find it very hard to bring a successful case against healthcare. But not so in the context of sleep apnea. The average damage is about $2.5 million. So all this set us on a path to create some kind of protocol for the management of these patients. So we're going to talk about why we created it, which is obviously the reasons which I just told you, the bad outcomes, and what challenges and limitations we were working under at that time, and how this multidisciplinary effort went into place to create this protocol. So in the year later, 2006, the Joint Commission put out a national patient safety guideline that mandated all hospitals to screen for patients with sleep apnea. However, one little problem was that there were no recommendations of how to go about screening at that time, and neither there were any appropriate screening tools. However, at BIDMC, we had already put into motion to create some kind of a screening tool to help manage these patients. So we developed a protocol for the screening and management of patients with suspected sleep apnea or with diagnosed sleep apnea, and we put that into place in 2008, around the time when there was a market crash and the stock market was falling apart. So this effort was a multidisciplinary effort involving surgeons, sleep doctors, nurses, respiratory therapists, and anesthesiologists. At that time, we did not have any guidelines, and we called this screening tool the Boston Screening Tool, BOSTN. I'll come to that in a little bit later. And we started implementation around May 2008, and at the same time, a landmark study was published by Dr. Francis Chung, showing us how to screen for sleep apnea. And in fact, many of the items we had on our screen were mirrored in that study too. And so far, after nearly many years of doing this, we have close to screened over 500,000 patients, and successfully so. So the first question we have to answer is: does diagnosed sleep apnea increase perioperative morbidity and mortality? I mean, is it worth going through all this? And there is some answer in the literature. So, and there are two studies here on the screen, and the top one is from the VA system, where they looked at patients who had total joint replacement. And the bottom one, again, was from Francis Chung's work, and the incidence of sleep apnea and cardiovascular events in patients undergoing major non-cardiac surgery. So the findings were, in the first study, from the VA system, it was an accumulation of 17 studies. The risk of respiratory failure was about 2.5 times, and cardiac events postoperatively was about 1.6. ICU transfers also happen more frequently. Again, another 2.4. Odds ratios were about 2.4. So clearly, there's a problem with sleep apnea patients. The POSA study from Francis Chung also showed similar numbers, and that there was a kind of a sliding scale for the risk of complications after surgery. These complications could be myocardial injury, death, heart failure, thromboembolism, stroke. And as you went from mild sleep apnea to severe sleep apnea, the risk of these complications increased. However, statistical significance was only shown with patients with severe OSA, adjusted odds ratio of 2.23. Also, there was a big impact of sleep apnea on postoperative resource utilization, even if these patients did not have significant complications. And the study at the bottom from France put together many studies together and came up with kind of incidences of issues diagnosed sleep apnea patients can have after surgery. And I can see the respiratory failure is about twice as high, acute hypoxia 2 to 3 times, reintubation risk is higher, cardiac events are higher, and delirium as well. And all this results in nearly close to an odds ratio of 3 for transfer to an ICU or a highly monitored setting for further care. So why does this happen? So if you look at our anatomy here, there is a blocked tongue which falls backwards, and of course the airway is blocked. And so when the patient inhales, air basically does not get past the tongue. And so that creates a negative pressure in the upper airways and transmitted down to the lower airways. But remember that there's only one other place where there is gas, and that place is the stomach. So these patients, when they are trying to inspire against a blocked airway, have two things happen. One is they develop negative pressure pulmonary edema. And the second thing is they create a siphon effect by which acid is pulled up in the esophagus along with hydrogen chloride gas. And then eventually it gets into the airway. And this happens obviously much more when the patient is supine. The negative pressure edema is also another problem where normally when, with breathing excursions, the negative pressure is -10 with an open glottis. However, when the larynx is obstructed or there's a tongue right above it, which is the same thing, your negative pressures go up to -100. And that's where there is transudate rather, coming in from the capillaries that breach the capillary through the tight junctions and get into alveolar spaces. So let's pause for a second and look at what we have discussed so far. So there's enough evidence in meta-analysis and individual studies to suggest that there is an increased risk of respiratory complications, cardiac complications, delirium, unplanned postoperative ventilation, and ICU care, in patients with diagnosed sleep apnea. And the odds ratio range from 2.4 to 3, depending on which study you look at. All right, so the next question is, obviously, we need some kind of screening tools. But the question is, why can we not do cases without screening? The problem is the vast majority of patients with OSA remain undiagnosed when they're present for surgery. There are some studies to say nearly about 3/4 of these patients with OSA may remain undiagnosed. Overnight polysomnography is very expensive and time-consuming, at least in the United States, cannot be done at short notice when patients are routinely getting booked for surgery within a week, 10 days of diagnosis. Patients who do get diagnosed with OSA are often non-compliant with CPAP. And of course, the most important advantage is routine screening increases preparedness for surgery. Anesthesiologists, change their techniques. There is adequate postoperative care. And then subsequent screening and diagnosis gives the patient some long-term benefits. So what screening tools? We have many. There's so many that, and whenever there are many screening tools, or, there's always none of them are really adequate. So Satyakrishna Ramachandran from our department did this analysis, looked at various clinical screening tests for obstructive sleep apnea. And the issues are the test accuracy and repeated validation of the same tool in a different setting is variable. They have a high false negative rate. And so patients with true OSA may be missed. And finally, the Berlin questionnaire and sleep disorder questionnaire are two more accurate questionnaires, but morphometry and clinical measurements are the ones which are more accurate. So in summary, the screening tests all have high sensitivity and low specificity. And sensitivity and specificity varies with the severity of the disease. And high sensitivity may lead to increased resource because now you are pulling in patients who have a low likelihood of sleep apnea. At the same time, there are some high false negatives, and that suggests that we may be missing some patients. So the next question we want to ask is, okay, I screen and a patient screens positive for sleep apnea. Do patients with screened sleep apnea have a worse outcome compared to patients who are at low risk for sleep apnea? So there are studies which give us an answer. So again, Francis Chung said that the pool's odds ratio for perioperative complication was higher in the high risk category with an odds ratio approaching 4. And the mean hospital stay was also longer by a couple of days. And this was published in ANA in 2017. So clearly, the patients who do screen high risk for sleep apnea have an increased risk of perioperative complications. Again, Krishna Ramachandran and Jaideep Pandit also published a similar study, but they used a different screening tool called the PSAT score. And again, they reported that, independently associated with increased risk of postoperative respiratory complications, or PRC. And so patients who screen at high risk for sleep apnea do have increased complications. They also found out that the use of neostigmine also increased the adjusted odds ratio of early intubation. Whereas if you did avoid neostigmine, the odds ratio came down. So yes, patients who do screen high risk OSA do worse than patients who screen low risk. But then it doesn't stop there. It gets even more interesting now. So here's a very interesting study from Denver, where preoperatively screened obstructive sleep apnea patients have a worse outcome than diagnosed obstructive sleep apnea patients. So, and this made me shake my head initially, and then I realized what they were talking about. So they say that patients with screened OSA have similar adverse respiratory events as diagnosed OSA patients. However, they do use more resource utilization. For example, postoperative respiratory interventions like intubations, hospital use, and also mortality is also increased. So clearly, patients who are screened actually seem to do worse than diagnosed OSA. And their thought was maybe just screening alone, these patients does not help the cause, and there needs to be some other management changes need to be made for patients with screened OSA so that they can be managed better, and just the screening tool alone will not suffice. So they suggested multidisciplinary interventions are needed for these high-risk patients. So again, to pause and summarize, patients who screen at high risk of sleep apnea in the absence of other interventions will have an increased incidence of postoperative adverse events. Their hospitalized length of stay may be higher, and overall all-cause mortality may also be higher. And this may be due to lack of protocols to manage high-risk OSA patients on the floors and in the recovery room. And the use of CPAP, other kinds of monitoring, and other interventions may be something to think of when somebody is screened high risk for sleep apnea. So the question here is, can we just apply management protocols to everybody who screens high risk for sleep apnea? Well, the problem is close to a quarter of all perioperative patients will screen at high risk for sleep apnea. And if we applied CPAP treatment and put them on a monitored bed on the floor, that would be an extraordinary ask of resources from the hospital. So 25% of our volume is a huge number. Not only that, there would be a huge non-compliance issue. So we had to do something to further filter down the patients who had screened high risk. In other words, we needed to apply some kind of a secondary triage to these patients. So we need to further define the high-risk population. So here comes a very, very important study, and one of the best I've seen in a long time. This comes from Mayo. It's a slightly older study, 2009, and where they looked at patients who were screened high risk preoperatively. And then they used a further secondary triage by monitoring them in the PACU. So they screen patients using the sleep apnea clinical score, which is based on a criteria called the Flemons criteria. And then all the patients were monitored for DSATs and pain sedation mismatch in the PACU. Then patients with high-risk screening as well as recurrent PACU events, they found that those two combinations, you screen high risk, but also you have some recurrent PACU desaturation. When you have the combination of those two in a patient, those patients tended to have more oxygen desaturation, postoperative cardiorespiratory complications on the floor. And this is elegantly shown by this graph, where you see on the column to the extreme left with a low SAC score, the incidence of complications of the floor was just 1%. And even when you had a high SAC score or sleep apnea clinical score, your complication rate doesn't increase that much. But then once you start having events in the PACU, desaturation or apneas in the PACU, then your subsequent your complication rate goes up when you go to the floor. It goes up from 11 when you have a low SAC and recurrent events, and then when you have a high sleep apnea clinical score and multiple recurrent events in the PACU. So this clearly it gives us some kind of a path forward that monitoring patients in the PACU or in the recovery room after they've been screened is a very important step in the management of these patients. So let's wind the clock back to 2008, and we are still developing our protocol. And when we came across the study from Mayo, and then we implemented some of the some aspects of those studies. So our Boston screening tool consists of 5 items. B is for BMI, O is for observed apnea, snoring loudly so that it can be heard in another room, daytime tiredness, and an X-axis greater than 16.5 in females or 17.5 in males. So these were the items which we chose to screen in a patient. And this is done electronically. So most of the information comes in, the weight is put in, and the next circumference is measured in the holding area or in the pre-admission test area. And then the other 2 questions are asked by nurses when the patient comes into the holding area for surgery. And this goes into an electronic medical record, and decision support options are provided to clinicians. And here's a screenshot of a patient with a high risk for sleep apnea. So you get a red colored warning here that the patient is high risk for sleep apnea. And if the patient is low risk, you would get something like this, where it says low risk in the same spot. And then if the patient had a previous diagnosis of sleep apnea, that is also indicated at the same spot. So using our electronic medical record, we are able to screen and allow highlighting for clinicians to change management as needed. So, and all this we published, later on, and in 2011. And this is a complicated flow chart, and it basically there are 2 parts to this, 2 sides. One is what to do with a patient with known sleep apnea and who is also CPAP compliant. And the second is what to do with patients who screen positive for sleep apnea or they are non-compliant known sleep apnea patients. So I'm just going to make this a little simple and get it down so that, so I'm going to go to the next slide where I simplify this. So you're just going to look at patients who screen positive or have OSA, but they're not compliant with CPAP. The first thing we do is to find out whether they had a general anesthetic or a sedation MAC or a neuraxial block. If they had a general anesthetic, they undergo what is called a sleep trial, not a sleep study, but a sleep trial in our recovery room. If they had a MAC, neuraxial block, or nothing, there's no need for a sleep trial. I'll explain to you in a minute what a sleep trial means. And based on the sleep trial, they have sleep apnea-related events, in which case they're deemed to have failed the sleep trial, or they have passed the sleep trial where they don't have any events. And if they fail the sleep trial, then we usually order for CPAP and page the respiratory therapist for CPAP equipment, and that's usually put on in the recovery room or as soon as the patient gets to the floor. If the patient passes the sleep trial, then there's no need for CPAP treatment or any further consults. And when do we discharge these patients? We don't necessarily keep them any longer, but the moment they reach the criteria, they are discharged or sent home. So what does it mean to fail the sleep trial? So the first thing we do is rule out central apnea. In other words, the patient should not be under influence of opioid medication. And the patients may also be back onto their baseline oxygen requirements, which is 2 liters of national cannula for patients who are getting admitted, and to be on air for outpatients. Then they are observed for about 30 minutes undisturbed, and during which time the patients must have 2 or more obstructive apnea episodes. It must be obstructive and within that 30 minutes. And then, in addition to that, they must have one of the other 2. That is either a respiratory rate less than 8, or they should have 2 or more desaturations of less than 92% during that same 30-minute observation. So if they have 1 and either 2 or 3, they're deemed to have failed the sleep trial, and then they get CPAP treatment if they're an inpatient. And so there are these decision support tools that are available for us to to order, CPAP, and it's pretty easy to do. Again, these are all built into electronic patient health records. And on the floor, basically, this is what happens when the patient gets discharged from the PACU. When the patient goes to an inpatient floor, whenever the patient sleeps, they're asked to put on CPAP. And so the patients who get CPAP are all known patients who are OSA compliant, all high-risk OSA patients who have failed the PACU sleep trial, and all known OSA patients who are CPAP non-compliant and have failed the PACU sleep trial. And on the other side, we don't initiate CPAP for the following patients, but we just monitor them. These are high-risk sleep apnea patients who pass the sleep trial, all known OSA patients who are CPAP non-compliant but have passed the sleep trial. So for the non-compliant patient, if they fail the sleep apnea sleep trial in the PACU, we actively encourage them to have CPAP treatment. But if they do pass it, we don't push that, but we do continue to monitor that. So this is, in a sense, what we do. So it's a three-step process. We screen, we triage in the PACU, and then we apply treatment or monitor depending on the results. So, and eventually we did publish this, the Boston study, and our primary objectives we aimed whether or not a high risk score on the Boston screening tool is associated with the requirement of postoperative mechanical ventilation within 7 days. And our secondary objectives were to find out whether there was a higher incidence of PEEP setting for these patients, or whether there was increased observation time in the PACU. And we also looked at some secondary objectives like in-hospital mortality, desaturations, new AFib, strokes, and healthcare utilization. And we published this in the ANA, and our findings were basically, that the risk of the risk of postoperative ventilation in patients who are high risk for OSA and who had followed the pathway was actually less than patients who are otherwise normal otherwise. And although higher odds of postoperative desaturation and were hospitalized for shorter periods of time. And so this was the findings on our study, and we continue to use the same Boston bundle, which was a three-part management of these patients. And finally, I just wanted to touch upon some of the guidelines put out by societies, and this is the SASM guidelines. So basically the summaries were patients with OSA undergoing procedures under anesthesia care are at increased risk of perioperative complications compared to patients without sleep apnea. There are screening tools which help stratify patients. There's insufficient evidence to delay surgery to confirm OSA by sending them to a sleep study. When we optimize patients, we should look at trying to optimize other conditions, comorbidities, which may have impact the outcome rather than trying to fix the sleep apnea problem. When other comorbidities are fixed and are optimized, patients should go for surgery and should not be waiting just from the basis of sleep apnea. The use of CPAP therapy in certain patients should be considered, and it should be continued to be used during the hospitalization. Again, the SAMBA, Society for Ambulatory Anesthesia, in 2012 put out similar guidelines, whether or not you can do patients with sleep apnea in an ambulatory surgery. So patients with known OSA and they're optimized and able to use a CPAP, yes, we can do surgery in an ambulatory center. Patients with non-optimized comorbid conditions, they need to be optimized as best as possible and are not suitable for ambulatory surgery centers. The patients with known diagnosis of OSA, again, if they're unoptimized, not suitable for ambulatory surgery centers. And patients with known diagnosis or presumptive diagnosis of sleep apnea, again, optimized conditions, and then proceed with surgery at ambulatory center. So in summary, OSA is associated with increased perioperative respiratory and cardiac, metabolic, and neurological complications needing ICU care. Screening questionnaires have high sensitivity, so false positive may increase utilization. Screening questionnaires also have false negative rates. However, screening questionnaires are the best we have, and we should continue to use them. Patients who screen high risk have slightly worse postoperative outcome when no further interventions are applied. So high-risk patients have been further triaged in the PACU, monitored or given CPAP treatment so that they don't suffer complication and there's efficient uses of the resources. So I just want to thank you, and I'll be available for questions later. Thank you very much.